actually, the metabolic medicine, this is a topic that has been taken from various parts. In some courses, we do not offer metabolic medicine as a separate one, and a number of areas of metabolic medicine which requires a high level of memory and a lot of theories here and there. Few diseases we even never encounter in real life most of the time. So first, metabolic medicine, the thing is, a number of diseases we will be discussing, most likely we are not going to see ever. But again, and in the part one, MRCP part one, again, you will not see anything. However, I have kept some picture over here, but usually this exam, you will not see any picture in part one. So we have to be familiar with the keywords which are important for this. So anyway, so we'll be doing a number of things. First, we shall be starting from the obesity and lipid metabolism. And people who have attended my class in the last time, during the last time, they know that I keep on writing a lot of things, and you can see those things. And since this is a very compact class, I would also request you to keep on writing simultaneously if possible. That is the best way to utilize this time. And very high yielding topics only are chosen for the class. And that's why very volatile. So if you keep on writing, that helps in retaining the information, especially metabolic medicine, not much to understand in most of the cases. This is actually biochemistry and applied biochemistry to some extent. So anyway, so first of all, we are starting with obesity and the basic idea about the obesity. So there are few hormones which are important for from the point of view of obesity, and of which the first thing that comes in our mind, that is leptin. Now leptin, how that acts? Leptin acts through leptin receptor, and they act in the satiety center. Leptin acts in the satiety center. Now where the satiety center is present? It is present in the hypothalamus. And where in hypothalamus the satiety center is present? It is present in the arcuate nucleus. So this is the area where leptin works and causes satiety. Remember one concept, we call it lipostat. So lipostat is the concept that every person has a highest possible body weight, and that is mediated by leptin. Suppose your current body weight is 70 kilo, but your lipostatic body weight may be 130 kilo. So whatever you eat throughout the time, whatever you eat, you will only reach up to 130 kilos. And after that, body will reduce the metabolism level and you can't exceed that. However, remember, one concept is also there, that is leptin resistance. And another concept is leptin gene dysfunction. So if these two things are happening, in that case, lipostat may not be respected. Body can go up. Once again, and another important thing here, that leptin resistance is something you need to think in terms of obesity as a cause of obesity. These things are the basic thing behind obesity. As a statement in the examination, question might come. The next important chemical which is important in terms of obesity is adiponectin, and this adiponectin is secreted from adipocyte. And this adiponectin acts in three pathways, and these three you need to just remember. I'm making it very, very small basically. So one is through adipo R2 receptor, through this, which increases hepatic insulin sensitivity. You all know that insulin is required in certain metabolism in liver, and this hepatic insulin sensitivity is important for maintaining the gluconeogenesis and other pathways. Next one, overall fuel utilization, and that is by AMPK pathway. These pathways are important, and here actually metabolic medicine and basic sciences are integrated, and it might come in the examination that way. And the third one, adiponectin, they are also very important as they are helpful in the reduction of vascular inflammation. So basically, these are types of adipokines, and there are three pathways where they act. Now, for the examination, what is required? Examination, we require leptin acting on arcuate nucleus, acts in satiety. The opposite one is the ghrelin, which is the feeding center, which acts on the feeding center, and that comes out of the stomach. This is one important area. And the second important area that you need to remember, adiponectin and their pathway and the receptor. So these are the important part for the examination. Remember one thing, adiponectin is indirectly proportional to overall body fat mass. So this is indirectly proportional to overall body fat mass. So a reduction in adiponectin will lead to multiple comorbidities like the diabetes mellitus, insulin resistance, coronary artery disease, and metabolic syndrome. And one of the very hallmark thing which goes quite closely to adiponectin is the fasting insulin level. So if the in case of low adiponectin, there is a correlation between fasting hyperinsulinemia. Remember, fasting hyperinsulinemia nowadays, as for many theories as those are coming, it is one of the very important hallmark marker apart from HSCRP, which is corroborative to the insulin resistance. So this very basic thing you need to remember before examination. Now coming to obesity. Now I'm coming to very classical MRCP topics over here, and obesity is a very important topic. Now many times I have seen they have asked question about the BMI. So remember, our BMI in India 23 is the cutoff, but NICE guideline, now you forget before the examination. Now you need to remember, as per NICE guideline, 18.5 to 24.9, that is normal in terms of BMI. Okay. And then we call overweight, and overweight is 25 to 29.9. This is overweight as per UK standard. Okay. Because they are a little bulkier, definitely. Then 30 to 34.9, this is, I'm talking about BMI, if somebody has joined late. So 30 to 34.9, this is obesity 1, stage 1. 35 to 39.9, it is obesity stage 2. And 40 above, it is obesity stage 3. So this is the thing. This 30 above is obese in their terms. In India, 25 above is obese. There, that is different. So this is something you need to remember. Very important thing. I would request you to keep on writing these areas. Now coming to obesity management. Again, questions will come from there. So 3 ways by which we can do obesity management. The first one is lifestyle modification, of which medical nutrition therapy is also a part of it. Then the second is the medical management of obesity. And the third one is the surgical management of obesity. And many questions do appear from these areas. Coming to that, do not neglect the diet. They are going to ask you questions from diet. So in UK, what is a normal daily requirement, calorie requirement? In case of male, it should be less than 2,500 kilocalorie per day. It is different from India. Ours is 2,000 and theirs is different. And in case of female, it is 2,000 kilocalorie per day. That is the daily requirement of energy. This is the daily energy requirement. If we remember, this one is important, of which all these points are important. Please do remember, all these are for question, of which total fat should be less than 30% of daily energy requirement. Again, important. Okay. Then, of which, always remember, saturated fat is actually discouraged, and they say it should be less than 10%. And they say the total fat, rest of the fat should be substituted by MUFA and PUFA. And trans fat should be 0. Trans fat should be 0%. So that is the thing. So MUFA and PUFA, these are actually encouraged. And saturated fat should be less than 10%. Now coming to the medical management, I will again discuss about the this issue actually in MCQ part. But before that, let's come to the medical management of obesity. So what are the medication and when we need to start the medication and when we need to stop the medication? Now I would ask some of you to say if you remember any medicine that we use for obesity. Anybody? Now you can say. Unmute yourself and you can say. Any volunteer.
Orlistat.
Orlistat, sibutramine.
Okay. Anything else? Okay. Let's. And when what do you think when we should give somebody anti-obesity medication? Somebody is having 31 BMI. Yes, come to you. Shall you start, Orlistat?
So first, we should try the diet change and exercise.
Okay,
And
how long?
strategies.
How long? Okay, good. So, and is there any cutoff of BMI where we should go for giving this medication?
Stage 2.
How much? Cutoff BMI? Okay, no problem. Let us good. At least names were perfect. Approach was good. No problem. So let us discuss the exact things. So as per the NICE guidelines, now you can mute simultaneously. BMI is more than 30. Initially, our approach will be diet, lifestyle, and behavior change. This is very important. Behavior change, habit changing things. These three, and for all these, they have persons to ensure these things. So healthcare workers are there for all three categories. Behavior change is extremely important. Okay, how long we should give this trial? This should be for the 3 months. Simultaneously, after 3 months, he should be revisited, and then further medication we can start. The second category is BMI more than 28 plus any risk factor or comorbidity is present. So BMI 30, no risk factor, plus no risk factor. Then this is the approach. BMI 28, then risk factor. Then again, initial treatment will be 3 months lifestyle modification plus risk factor modification. If not working, then we will start the medicine. In no cases, in this two condition, we will start medicine from day one. So what's the difference, you might ask? Because in both the cases, 3 months, we are waiting with other non-pharmacological way. The only difference is the threshold comes down if risk factor is present. And by risk factor, we mean to say it can be, and there are few risk factors. Remember, occasionally, most of us know that coronary artery disease is a risk factor, diabetes is a risk factor, high BP is a risk factor, but don't forget obstructive sleep apnea. That is also a risk factor. Always do remember. And occasionally, this obstructive sleep apnea is connected to the blood pressure, high BP. So whenever an obese patient with blood pressure is coming to you, think of obstructive sleep apnea, ask the question in your clinic, and here in the examination, try to find out what is the risk factor that is present, whether I am missing something or not. Now, suppose in both the cases, after 3 months, there is not good, no result. So we start them on medication. Okay, names of the medication I am coming slowly, but apart from that, we need to understand how long we should continue this medication and when we should stop the medication. So whenever these patients are put on this medication, every 3 monthly, they should be reviewed, and we should have to take a call to stop this medication. I'm talking about NICE guidelines. So we should have to take a call to stop this medication around 12 months if certain criteria are not met. So what is the criteria? Over 12 months, we continued the medication and we achieved weight loss very minimal, less than 5%. Stop. Second, patient is on medication anytime, not over 12 months, not over 3 months, anytime from the beginning, patient is on medication, maybe 2 months, maybe 3 months, maybe 4 months, he is on medication, and all of a sudden there is secondary weight gain. Patient is again gaining medical weight. Again, we need to stop this medication. And you might ask me why we have to review at 3 months if you are not going to stop this. The reason is to check whether any adverse effect is happening or not. That's the reason. Okay, so now we are coming to medication. So orlistat is a medication, and what it does, orlistat, it is an inhibitor of pancreatic lipase. So as it is an inhibitor of pancreatic lipase, it will cause an iatrogenic malabsorption. And that's why the problem is that there may be flatulence, there may be, malnutrition. And the major thing that patients complains that is oily diarrhea. So a kind of iatrogenic steatorrhea might happen when the patient is on orlistat. Okay, so again, the same process we have to follow. The second one is sibutramine. So sibutramine, this medication is now not there in UK market. It is withdrawn, first of all. So there is no question coming on this. If question comes, just one thing remember, sibutramine is withdrawn. So it should not be the answer. Just that will be sufficient for you. And extra knowledge is, it is a serotonin norepinephrine reuptake inhibitor. So it actually inhibits the serotonin and norepinephrine. Now, further mode of action, not at all necessary. This is withdrawn drug. It will not be the answer. The simple thing. And third one is rimonabant. So rimonabant is a drug which acts via cannabinoid receptor. So it is a cannabinoid, and this is CB1. The receptor name is the CB1. So cannabinoid receptor modulator. But again, it will not be the answer because it is withdrawn. Great. Now, what are the medications which are actually running? So now actually running medications are GLP analogs. So these are the medication. Of these, there are injectable GLP analogs, and there is also one oral GLP analog. Remember, GLP analog, the prototype drug was exenatide, and it was actually started for diabetes. And GLP analog, as you know, because the prototype was exenatide, and it was used for diabetes. It was a long time it is there. I mean, around 2010 onwards, there was a good use of exenatide over various parts of the world. But later, what is seen, that the people who were on this GLP-1 analog, they also achieve weight loss. So then the whole thought was channelized to that direction. And good medication for that is liraglutide, that is injectable, and semaglutide for oral. Apart from that, dulaglutide and others are there. But these are the two medications that we use for patients who are having obesity. Now, there are only two things that you need to remember. This medication should not be used in case of pancreatitis, not only active pancreatitis, but also patients who had a history of pancreatitis. And they should not be used in case of, if there was a history or if there was a family history of medullary thyroid carcinoma. These are the things that we need to remember for this. Okay, so this is all about the medication for obesity management. There are a number of literatures are available. These are the newer drugs, but for the exam purpose, I would suggest you only name, mode of action, and contraindication, and any adverse effect if there, you just have to remember. Next is surgery. So what are the surgery we do for this? We all know it is bariatric surgery, but is that enough? No, that is not enough. You need to know a little more about the bariatric surgery. First of all, whom should we ask or whom should we send for surgery? What is the cutoff for surgery? BMI more than 35. Okay, it is not equal to, it is directly BMI more than 35 plus risk factors are present. Okay, lifestyle failed, done but failed. Okay, drugs, medicine done but failed, or medicine contraindication was there. Whatever. This is the criteria for surgery. This people, whenever these three things are there, they will go for surgery. Second criteria is BMI more than 40, no risk factor. Again, there should be initial trial for this, and then we can send them to surgery. Again, nice guidelines we are talking about. And the third variety is BMI more than 50. In such case, first line option is surgery. So these are the guidelines. Again, surgery, there is Q and other things are important. Accordingly, we have to plan.